So this is Tante Lamini on the stage of Georgia in Atlanta. At this time at 12:16 on the 24th of January 2025, conducting an interview for the Global Oral History of PEPFAR project. Could you please begin, Dr. McCray, by introducing yourself and establishing your connection to PEPFAR and what years you worked for PEPFAR or in partnership with PEPFAR?
Sure. So I'm Dr. Eugene McCray. I started with PEPFAR actually at the beginning. Prior to PEPFAR, there was something called the Global AIDS Program, and I was director of that program. And we played a major role in working with the White House and the USAID and others to help develop the PEPFAR concept. So in 2004, when PEPFAR was being realized, I was very much a part of the process and continued to work in global AIDS until the middle of towards the end of 2004, November 2004, before I transitioned to mostly domestic work. But even in my domestic work, when I was working in the International Tuberculosis Program, we partnered with PEPFAR on a lot of operational and epidemiologic research related to tuberculosis and HIV.
Thank you for that nice overview. We're just going to go chronologically from the beginning, of your career. We want to start off by you telling us about yourself first and your family, where were you born and where did you go to school, etc.
Okay, well, I was born in a little country town called Wysocki, South Carolina. It's probably not even on the map anymore, but it's in rural South Carolina. I grew up on a farm. And I was one of 9 siblings, 5 sisters. And we were primarily raised by a mother because my father died when I was about 11 years old in a car accident. And so and that was sort of the early years. I went to high school there, graduated a little early, went on to college here in Atlanta at Morehouse College in Atlanta, Georgia. And then while I was at Morehouse is where I became interested in medicine and in health, because growing up, growing in a rural community, all I knew was farmers and people that worked in factories and things like that. So my exposure really came when I went to college and had the opportunity to travel and do a lot of things. So I got interested in health, and actually while I was a junior, during my 3rd year at Morehouse, I actually changed my career, changed my major from math to biology and pre-med, because I had an advisor who he said, look, we are really pushing to get more and more people into medicine. Your personality, your acumen, et cetera, I think you'll be a strong candidate, consider doing it. And of course, being from my community, I didn't know any doctors, nobody that looked like me. And so I said, yeah, I'll try it. And I did, and I applied to medical school. I took the entrance exam and applied. And did very well and ended up going to medical school. And actually, when I was in medical school, I had no thoughts about going into public health. My goal was, when I started, was to become a primary care provider, do general internal medicine, and then and move on. But when I was in medical school, I got interested a bit in public health, and actually had a little incident in medical school where I was actually asked to stop doing work. We were working in the African American community trying to do hypertension prevention, diabetes prevention, and just educate people about the things that they can do to protect themselves against those 2 diseases. But we also had part of it, an anti-smoking campaign. Well, I was at a medical school called Bowman Gray School of Medicine, which was primarily financed by the Reynolds Corporation. They were big tobacco people. And so I was called in one day and told by the dean that we needed to stop the work that we were doing because it was causing problems. And so, as a medical student, I decided that, this is probably, I want to do more in prevention, but I wasn't thinking about the CDC. I had never heard of the CDC. So then I went on to residency at the University of North Carolina in Chapel Hill in internal medicine. And then while I was there, during my 3rd year, I had decided I wanted to go on to do an infectious disease fellowship. And I was interested in preventing hospital-acquired infection or nosocomial infections. And I got into a program. And then about 6 months before I had to make a final decision, the person that I was going to be working with decided he was going to be leaving to go to a different school. I was going to go, it was at a program in Virginia, at the University of Virginia, and he decided he was going to take a leadership position in Iowa. And I was not interested in going to Iowa, so I said, I need to go to my plan B. And my plan B was to just do private practice. But I had a mentor at the time, and he said, do you know anything about the CDC and the EIS program? And I didn't know anything, so I looked it up and read a lot about it. It sounded very interesting, and I decided to apply. And that was really the education that I did of myself to learn about that program is really what got me very interested in public health. And I realized it was sort of aligned with the things that I wanted to do in life, because I wanted to make a difference. For me, going to medical school wasn't about making a lot of money. It was about making a difference. And I had hoped at some point I'd be able to go back to my community and make a difference there. So that's how I ended up at CDC, basically because my infectious disease fellowship didn't work out. I ended up going to CDC to do EIS, the Epidemic Intelligence Program. And it's the Epidemic Intelligence Service Program. And it was a life-changing decision and probably one of the best decisions I've made in my entire life.
Thank you so much, Dr. McCray. I think you've sort of spoken about the next point I wanted to talk about, like your career background. It's clear now how you got into HIV and CDC specifically. You're also saying that you didn't know anything about CDC at that time until a mentor mentioned it to you and you looked it up. So it's the same thing with PEPFAR. Most people do not know much about PEPFAR. So for you, how would you explain, like the first time you heard about PEPFAR is when you got connected with CDC. So if somebody would ask you to explain, what would you explain PEPFAR to be?
Yeah. Well, so let me just back up and clarify a couple of things. When I came to CDC, it was in 1983, and that was during the early part of the HIV epidemic. And so I was primarily at that time focused on hospital infections. I was lucky enough to get assigned to the hospital infections program. And when I was there, I had the opportunity to work on preventing HIV infection in healthcare workers, because one of the things that was happening is people were very afraid, of course, of take care of people who were living with HIV. So there was people were getting stuck by needles. They were getting exposed to bloods from people who had this disease called AIDS. And so we had to really develop the evidence to show that it was safe for people to work with these patients as long as they used appropriate precautions. So I did something called the healthcare worker study, and that's how I sort of got involved in HIV, because I didn't go to a CDC with the intention of getting involved in HIV. But while I was doing that, I got asked to do some work in the HIV program, and then as I finished the EIS, transitioned to HIV. So my first 7 years was really domestic HIV. There was no global HIV program at the time. But it was like in 1992, 93 actually, after I had gone away to do an infectious disease fellowship in Washington, I came back to CDC and I was asked to get involved in the National Tuberculosis Program. So I did, and then as a result of that, I was asked to work with the global tuberculosis program on really getting people who were diagnosed with TB. Many of those people also had AIDS or HIV in Africa. And one of the things we wanted to do was to try to make sure those people, when they got infected with tuberculosis, they could be cared for in their communities. Because back then, everybody stayed in the hospital for 2 months before they were able to go back to their community. But anyway, that's how I got involved in global. And at that time, there was no global AIDS program. There was no CDC global AIDS program. There was no PEPFAR. So in 1999, during the Clinton administration, because of some of the work that we had been doing we meaning CDC collectively had been doing in Africa and other parts of the world, mostly research, we were really highlighting the problem that was happening with HIV and AIDS in Africa and Asia and certain parts of South America. So the Clinton administration provided some funds, about $29 million, to do an initial assistance program, HIV assistance program in Africa. So we started out with 14 countries in Africa, and then we had some regional sites, one in the Caribbean, one in some sites in Asia. And then that program got started, and with over a 4-year period from 2000 to 2004, that program expanded to almost to 25 countries in 3 regions that included South America, Asia, Africa. Most of the countries were in Africa, of course. And then during the 4th year of that Global AIDS program, we started, there was a lot of discussion about doing something big. And when George Bush when Bush II became president, we were asked to think about something big that the president could do that would make a difference in Africa. And at that time there was, and I believe this, at that time there was a lot of bipartisan support for HIV, both domestically and globally. And so we initially started a program called the Prevention of Mother-to-Child Transmission Initiative, which many people don't know about, but preventing transmission from mother to child was a big deal. And that's one of the areas where we had a lot of good evidence to show that if you treated women during pregnancy, they would not transmit to their children. So anyway, the unborn child. So anyway, that program was very successful, and we were able to demonstrate that you could do this very well in Africa, and people could take treatment and just so forth and so on. And so we worked together with the U.S. Agency for International Development, with State Department, and with the White House, and a number of others to really put together this PEPFAR, President Emergency Plan for AIDS Relief. And I was one of the principals involved in helping to plan that. And a lot of my staff were involved. And so that got started. I guess the legislation went forward in late 2004, and it was authorized in 2005. And that was, to me, one of the most successful, one of the biggest accomplishments, during my time at CDC, was really being a part of that, getting that on the ground. But after that, I was exhausted. And so I decided after 5 years, or 4.5 years, to move away from, to take some time away from global health, because I needed to recover. Yes. And that was too much, yeah. And so I moved away for a while just to take a break.
Thank you so much. So when you come to the CDC, 1983 is like initial stage for HIV, US and everywhere. So can you just tell us what was the state of the American involvement, government involvement, as you saw it in combating global HIV pandemic before PEPFAR came in?
Yes, so there was very little engagement, actually. Most of our work in the global arena was in the area of providing sort of technical assistance and support. We were providing assistance to do surveillance, to try to count the number of cases that were being diagnosed in different parts of the world. And we supported the World Health Organization in that effort. We were doing research, and the research is actually, I think, the most important, and the part that really convinced what we used to convince others that we needed to be doing more. But as part of that research, we had research stations in the Ivory Coast, we had one in Thailand, and we had one in Kenya at the time. And then we later established a research program in Uganda. But those research programs were actually looking at preventing HIV, and they were mostly prevention program. Because at the time, there were people who didn't believe that we could effectively treat folks in Africa or in developing countries because there was no infrastructure. And we then during my tenure as the director of the Global AIDS Program, we basically were able to get some funding to support some treatment programs. These were demonstration projects, or what we call operational research. And we were able to show from these demonstration projects that not only could we treat people, but the patients in Africa were more compliant at taking their drugs than what we were seeing in the US. And it was basically those data that helped us convince the politicians, when we provided them with the evidence to show that treatment can be effective. We had great outcomes. people were adherent on the medication. We were not seeing a lot of resistance, et cetera. That then they started thinking, well, maybe we can do something. And that's sort of how PEPFAR sort of came to light, because we were able to show that basically with the appropriate amount of support and engagement by community, government, et cetera, and private partners, we could actually make a difference, and people could get treated effectively in developing countries, and particularly in Africa. So, but it was not until that didn't happen until the 1999 was when we got the first funding, but in 2000 is when we really got very engaged, and that was when, and then 2004 PEPFAR came out. Late 2004 PEPFAR came along.
Thank you. I think we're just going to go around because you're going ahead as well throughout your whole career and how everything else ties up together. But I mean, we will get to some of these questions in even more detail when we get to that.
Yeah.
So because I'm interested to find out, like in this demo project, you're saying that you are showcasing compliance of the African people in taking medications. Like for instance, what were some of these ambivalent issues that people were having that made them think that they will not be able to comply?
Yeah. So for example, let's take the example of rural Kenya. Our research project in rural Kenya was in an area that had really no infrastructure. There's no running water, as you might expect. Access to clean water was a problem. So how are people going to take drugs if they don't have clean water to drink? There were issues with food insecurity. In order to take these drugs, you need to be able to eat food appropriately, you have food to eat, et cetera. And then, of course, there were some folks who thought that because of the educational level, people would not be able to do this. But we had evidence from our work in tuberculosis where we can engage the community, and we just with minimal education of the community, people were able to take their drugs. We were able to work with our partners, USAID, some of our global partners, et cetera, to make sure people had access to water, clean water, to address the issue of food insecurity in many of these communities. And that's where the U.S. Agency of International Development played a major role. And so by making sure people had access to just the basic needs, people were very willing to take medication and so forth. And then the other thing that I think was important was, which I can't stress enough, and you've heard me say it a few times, is the community involvement. It was so important in Africa to make sure the community was on board and fully engaged because there was no healthcare, there was very limited healthcare infrastructure, and that's why people were concerned. But because of the community involvement, and you had a lot of community organizations that were actually involved in delivering medication, making sure people had food, and so forth and so on. So that really made a difference. And so I think that those concerns were really addressed by these demonstration projects that showed great outcomes. And then the other thing we did is we took people on tours. We would take politicians to Africa and show them these programs. And when they saw what was happening on the ground, I think it helped to convince them otherwise.
Thank you. I'm just trying to figure out how to go about with this because, I think this is interesting. I'll just go ahead with this because I know that you were part of Secretary Thompson's trip to Africa, and that kind of trip happened, and you were part of it, and people went to Africa and were able to witness what is happening on the ground. But before we get there, so you're talking about community involvement was very important. So like for instance, so there were these other partners that came on board, like for water, you said was helping for food and for all of that. So what was the particular role of the community? Like if you can just say, this detail, what did they really do that made a difference in how this treatment was being taken and was able to turn the tide in how people were perceiving?
Sure. So it varied by communities because the communities had to be engaged in the implementation so that we were doing. So in different communities it was different. So for example, in some communities we would identify what we call community health workers. And these were public health workers who were basically underutilized, and those people would then go into would be from that community, and they would be the ones that would help with making sure the patients got their drugs every day or every week, and then they would go in and help what we call monitor the patients and make sure they weren't having side effects from the drug. So these were what we call community workers. And then we had on top of that people that the U.S. government through the embassy employed that were people who would go out and monitor what was being done and support those community health workers. The other thing that we did is that there were, in many of these countries, like in Uganda, there were a number of what we call AIDS support organization, something called TASO, the AIDS support organization. Well, TASO was very engaged from the beginning, and a lot of their work was really focused on just supporting people. But getting engaged with TASO and community organizations like that, they were able to provide a lot of the support to patients, the making sure that people got help, making sure people got water, making sure people got food, monitoring them for their medication, et cetera. So they did a lot of things like, it ranged from us having relationship with community-based organizations like ATASO, the AIDS support and us working directly with health workers, community health workers to ensure. There were also a lot of unpaid volunteers at the time. And so there were people who, in many cases, the community would identify someone that they trusted, that they were willing to have come into their home and provide the kind of support they needed. So community volunteers are also a big part of this. And they would get little things. I'm not necessarily monetary things, but they'd get, clothing and different things for support. You'd give them a bicycle maybe or something like that. But the community volunteers were critically important. And the one thing I need to really say, some of this worked better. The engagement of the community and the community volunteers worked really good in rural areas. It didn't work as well in urban areas because, as you might imagine, in an urban area like Kisumu, not Kisumu, I mean like Nairobi, there are many people coming from many different regions and from different tribes, et cetera. So there's not as much of a community as you were. It's a different kind of community. So your strategy had to be a little different if you were in a city versus in a rural area. But these strategies work very well in rural areas, and I think it made a huge difference.
Okay, so now I'm going to go to your initial role at CDC,
Mm-hmm.
that of being the Epidemic Intelligence Service Officer, which you started out in 1983.
Mm-hmm.
I've done my research correct?
Yes.
So you have told us how you ended up there. So I would just like you to explain to me your everyday. What was
Sure.
your everyday like in that particular role that you were playing?
Yeah. So as an EIS officer, there's sort of three areas that we get involved. Well, there are more things, but the three major areas is we always have to do what's called a surveillance project, where we try to understand. Basically, surveillance is counting disease and then is collecting data and reporting that information back and then using it to make a difference. So surveillance for disease. And then the other area was doing an epidemiologic study, where you do a study that help addresses a problem. And then the big part, though, is outbreak investigations. So I was in something called I was in the hospital infections program. And we basically investigated outbreaks in hospitals or hospital-related outbreaks. So, for example, one of my first outbreak that I went on was an outbreak in a nursery in Canada, in the big what we call a tertiary care hospital, in a nursery where there was a big outbreak of viruses that were killing newborns. And we were able to go in and within days identify what the etiology was and then put control measures in place to stop the outbreak. And then after about 2 weeks of working very hard, we were able to control the outbreak and then were able to come back. And then, of course, whenever we did an outbreak, there was always a laboratory component involved. So we worked very closely with the laboratory, and they were able to help us very quickly identify what the organism was. And then we knew that of course, what appropriate treatment would be. So as an EIS officer, my day-to-day work was really, I also had a surveillance project, and that was the healthcare worker surveillance project that I mentioned earlier. So as I mentioned early on, we needed to understand whether healthcare workers were at risk from getting HIV from needle stick exposures, blood exposures, cuts, things like that. So the project was started just before I got there, but then I took it on, and we had sentinel surveillance in multiple places around the country, but hospitals knew that if they had a healthcare worker that was exposed to blood or body fluids from a person who was admitted with AIDS or HIV, that they could report that person to CDC, and then we would come out and we would collect blood and do a number of things. So anyway, my day-to-day work was really making sure I was following up on all the reports that were coming in about healthcare workers who had been exposed. And this was passive reporting. We had no capacity at that time to do what I call active surveillance, where we actually went out and tried to find people who had been exposed. But this is passive reporting. So that was my day-to-day stuff. And then I did the outbreaks. The EIS program was a 2-year program. And during that 2 years, I did 6 outbreaks. And of course, I was in a program where publishing the results of what you learn was important, and then making sure you develop guidelines to prevent things as in the future was really important. So during that time, it was expected that for each of the outbreaks that I did, that there'd be a publication and there'd be an after action sort of report, so that we could try to prevent those things from happening in the future.
Thank you. Those are early stages of HIV, and you were like right in the front line of that, trying to make health workers be comfortable and assure them that they will not be infected with all of that. So what were the kind of issues that you were able to see, like especially because I think I read somewhere that you would also go to communities, prisons, and hospitals, what you spoke about. So
Yeah.
Let's talk about communities and prisons. Like what were your experiences and encounters like in those early stages?
Yeah. So in the early stages, as I mentioned, we didn't really know. At first, we didn't know what was causing the infection. Once we knew it was HIV, we had a lot of we basically treated it like we knew what we knew. We took the information we knew about viral hepatitis and said, this can be blood transmitted by blood and body fluids. So we implemented a lot of the same precautions we would have done if somebody had active hepatitis infection. But so basically, healthcare workers were afraid. They didn't know they didn't know what to do. And so when we went to communities, one of the big things we had to do was really try to get communities to understand how the disease was spread. It wasn't, we had to make it, let's say, you're not going to get the infection by being in the same room with a person that has HIV, because it's not spread by air. You're not going to get an infection by hugging someone that has HIV, because unless you're having sex with them, exchanging body fluids, etc., you're not going to get infected. Or if you're exposed to if you're not exposed to their blood, you're not going to get it. So a lot of it was going out to the community and educating them. There was also, at the time, I don't know if you're too young to know, but there was a community in Florida where there were a lot of Haitian immigrants, people who had come from Haiti, and there was this concern that mosquitoes was transmitting the virus, that the Haitians were infected and they were spreading the virus through mosquitoes, et cetera. And we had to do, I didn't personally do it, but a colleague of mine and good friend did a big study there where they were able to show that there was no mosquito transmission of the virus. So that was community. Then I went to hospitals and I had to go to prisons. And again, in hospitals, with healthcare workers, a lot of it was then education and letting them know that if they got exposed, there were things that they could do to so that we could follow them and make sure we are documenting what's going on. And so a lot of it was just talking about infection control precautions that they need to follow. In the prisons, it was a little bit more complex because the prison guards were not willing to take care of people. I mean, they were basically isolating folks who were coming in with AIDS and they weren't getting any care in the prisons. So a lot of it was really educating the prison guards about things that they can do to protect themselves, and also making sure they understood that in prisons, there was a lot of, during the early years, there was a lot of TB, HIV, tuberculosis, and HIV co-infection. And we were seeing a lot of that in the prisons. Getting the prisons to getting prisoners, the prison administration to understand that when you have HIV patients coming into the prison, you need to make sure they're segregated from people who have active tuberculosis infection, because they can get infected very easily and they can die from the TB infection if they have HIV. So a lot of it is just education about how the disease is transmitted, things that they can do to protect themselves, and then things that they should do to care for the patient and prevent acquisition of the disease in people who were immunocompromised, especially the HIV patients.
Okay. So did this look different in underserved communities, or would you say there was a difference at all, or it was unanimous?
It was, well, during the early days, a lot of attention was given to HIV in the white community. There was not very much happening in the Black and Latino communities, even though there were a lot of infections happening. And so they took a lot of activism in the community to really bring attention to that. But there were some folks at CDC who were paying attention to it. There were people like the Helen Gales, and that name may ring a bell to you, but the Helen Gale and others, and even the epidemiology was beginning to show that Black communities, especially Black women, Black men, were being infected, even though we're being infected at a higher rate than white. Even though the whites had the large numbers, the rate of infection was not as high. So there was, and the resources were not going to the community. So due to a lot of going to those communities, so due to a lot of activism in the community and working with with congressional staff, especially the Black congressional staff, at some time, I think it was in the late 90s, early 2000, there was some funding that did become available to support special initiatives in Black and Latino community. So the Congressional Black Caucus at that time played a major role in making that happen. Mm-hmm. And I think it was called the Minority AIDS Initiative is what it was called.
Mm-hmm. Okay, you mentioned that 1999 President Clinton committed some resources to HIV response, which was targeted to 14 countries and went to 25 countries.
It grew to go to 25. Mm-hmm.
Yeah. Mm-hmm. So can you just explain to us, like, what was the focus during this time and those resources? Because that will make us, roll over to PEPFAR.
So. Sure. So in 1999, when those money came, the goal was to develop sort of some what we call HIV assistance programs. And at the time, of course, treatment was not readily available, even not as available in the U.S. as it should have been. So our focus at that time was really on education and prevention. So our initial programs collaborations that we did in those 14 countries were to really focus on what we call information education campaigns, IEC. We also focus a lot on diagnosing people and educating them about things that they can do to prevent transmission to others. At the time we were talking about condom use. We were talking about abstinence, if possible. The ABC, if you could abstain if you can. If you cannot abstain, use a condom, and then be faithful and then use a condom. That was the big thing in a lot of countries, ABC. And then the other part was prophylaxis treatment. We wanted to make sure when people were diagnosed with HIV, since we didn't have treatment available, we wanted to make sure they got access to drugs to prevent opportunistic infections like pneumocystis carinii pneumonia. So making sure they have access to Bactrim, preventing things like cytomegalovirus infection of the eyes and things like that. So a lot of it was just what we call prophylaxis to prevent opportunistic infection. And then we quickly learned that was not enough. And we really needed to do what we could to get treatment there. So during the third year of the program, several of our projects working together, several of our projects that had a research component in Ivory Coast, in Uganda, in Kenya, they did some small studies, 500 to 1,000 patients, and we were able to secure antiretrovirals working in partnerships with some private sector, with some of the pharmaceutical companies. And we're able to demonstrate, we weren't the only one that were doing it, but we were leading a number of these initiatives. We were able to demonstrate from these projects that treatment could be effective. And basically we, as an agency, decided that it was really, not to use the word criminal, but we're really unethical for us to be redoing research in these countries and not making treatment available to people that were involved in these research studies. And that was the argument that we used. It was an ethical, I think a sound ethical argument. We got ethicists involved, they had all agreed, and we were able to convince our government that the funders that we should be providing treatment. And then of course that information was very helpful in informing what eventually became PEPFAR, because the treatment was very effective. People were getting well, and we were seeing decreased transmissions as a result of it. But then the treatment came later. Early on, it was really just prevention, and even condoms became controversial, as you might expect. But in Africa and Asia, condoms were a big part of the effort to prevent HIV transmission. But as you might imagine, there were social issues that created a lot of problems in some areas. For example, women, because of their status in many of the communities, really had no power. So they couldn't insist that their husband or their partner use a condom. So many times they were not being protected. And female condoms were not very practical in a lot of them because again, the partners wouldn't allow them to use them. So there was a lot of challenges at the time, but I think that getting treatment into the countries really made a huge difference, and that's what PEPFAR is all about.
So you're talking about the issue of ABC being the focus back then.
Mm-hmm.
And of course, there were those issues, patriarchal society and the power of women to negotiate the use of condom and all of that. So this seems like that was the basis in which, the global response to HIV started from, especially for US to support Africa. So, how did we transition? Would you say that behavioral change is also the focus or not? And how did it get dropped out?
Yeah. No, behavioral change was also a big focus back then. And I forgot to mention that because the behavioral change communication was a big part of what we were doing. But behavioral change takes a long time. And it's very challenging to change behavior. So even though we continued to do it, it became less and less, it became not a major part of the program as we moved forward. And we had access to more resources to do prevention as well as treatment. So behavioral change was important. So behavioral change communication, there were huge campaigns in all of the countries that were related to behavioral change. The other thing that I think was, and the behavior change targeted different parts of the community. The behavioral change that were split to targeting men, a lot of men and boys, there were behavioral change activities targeting them, but also behavior change activities targeting folks who exchanged sex for money, folks who were involved in the transportation, long distance transportation, et cetera. So there were a lot of behavioral change communication programs that targeted those types of folks where there was a lot of HIV transmission occurring.
So basically, drugs became more effective to have a better impact to a lot of people across different populations than behavior change would, and the fact that it takes a long time to get that kind of effect that you need, and hence more focus, went towards treatment and prevention.
Yeah, and I have to say, even though behavioral change was something that was more difficult to convince politicians because the data just you weren't going to see change immediately. This was change that you might see 10 years down the road. And so that was not a very appetizing strategy to get politicians on board and get the support that we need.
Okay, so PEPFAR is announced. Where are you in your career, like in your trajectory? Where are you, and what are the sentiments? I mean, what did that mean to you?
Wow, that was PEPFAR was huge because and I would say I was mid-career. I had already been. It was 2004, late 2004. I had already been at CDC for 20 years, and so it was mid-career sort of late mid-career for me, and I felt as though I was a big part of the process because of the work that we'd done. It sort of built the foundation for PEPFAR. What we did not talk about was, a lot of the research that we did in those early years during 1999 to 2004 was on prevention of mother-to-child transmission. And because of that research, we were able to show that you could prevent transmission from mother to child, and saving babies was really important to politicians. And we used the Prevention of Mother-to-Child Transmission Initiative as the evidence to show treatment works. We need to be treating all these pregnant women if we want to keep babies from getting infected. And who could say no to that, right? So the PMTCT initiative is really a big precursor to PEPFAR. So when that initiative was so successful, and then they were able to convince the president that he should support PEPFAR, we were all elated. And of course, for me, the crowning, the moment that was really important was when I had the opportunity to go to the White House to be there when President Bush made the announcement of the.
You already knew that was going to make that announcement?
Yes, those of us who were in, we knew that he was going to make the announcement. We were part of the few that knew, and we were invited to be there because we were so much a part of the process. So that was one of the highlights of my career, just being able to be there when that announcement was made. It was big. And of course, in that announcement, it wasn't just about treatment. It was about prevention. It was about addressing the orphan situation in many of these countries. So, making sure we support orphans. And then it was also about, so it was basically orphans is preventing infections, treating infections, and then doing what we could to improve the surveillance and data collection in those countries.
Could you clarify by orphans, what interventions were you doing specifically?
So that I think, as you know, one of the things that happened in the epidemic, especially early on when there were no treatment, there were lots of parents, both mother and fathers, who were dying. So there were lots of orphans in the community, and so making sure there were resources available to get orphans into places, get them off the street and into homes, and support them in the communities where they were. So there was actually a lot of support provided to supporting orphans and making sure they had places to live, food to eat, etc.
Okay. I just need clarity whether it was a medical response.
No, it was more. It was a social response, recognizing the fact that there were lots of orphans, and those orphans were being luckily in many of the countries, when a parent dies or both parents dies, there are other family members that take them in, but those families struggle. So making sure they have the support they need to take care of the many orphans that needed care.
Okay, so 2 years into your new job at the Global AIDS Program, when you're the first director, then the PEPFAR is being announced. So why did you want to take this role? Why was it important for you to take this role?
Well, there were several reasons. One is, and part of it was personal, and I wouldn't say selfish, but personal.
The personal.
The personal, yeah. Well, personal because, here we are, doing an initiative that's primarily involving Africa. And all of the faces of the people that were in leadership role in PEPFAR were white, not people of color, not Black. So for me, it was really important that I be there and be one of the leaders that people saw when we went into countries. And I think it made a difference when folks saw that one of the leaders that was involved in the early response to HIV in Africa happened to be, at least from CDC, was a Black person. And that's why I think, I keep mentioning, I mentioned Helene Gayle earlier. She was one of the first people that recognized this as a problem and was actually doing stuff when she was at the U.S. Agency for International Development to really bring attention to this problem in Africa. But there were not very many Black Americans at the time that was engaged in the global work. And having people in leadership role as part of this initiative was really important. And I thought that from a personal reason, I thought it was important that I at least continue to be there as much as I could.
Mm-hmm. So that was personal reason. So professionally?
Professionally, I just thought that, I thought I had a lot to offer because of my experience, starting the Global AIDS program, and because one of the strengths that I know I had was the ability to work effectively across agencies. In order for us to have a successful Global AIDS program, I had to work with many, many different parts of government, USAID, HRSA, which is the Health Resource Services Administration. I had to work with different parts of Health and Human Services, other parts of Health and Human Services. We also worked with Peace Corps, with a number of others. So we had already had relationships with a number of those partners. And when PEPFAR came along, of course, it became an all of government and involvement. And so many of these same agencies were going to be involved, but in a bigger role, And so given my experience working across the U.S. government and working with the international agencies, World Health Organization, UNAIDS, with the Global Fund was just about to be established, but and then working with national partners, other national partners, with Med Sans Frontières, with the Dutch, the Dutch KNCV, which is the Dutch National Association that was involved in both TB, tuberculosis, and HIV. So I had that experience already from the work that I had done in Global AIDS. So I thought I had something to offer, and I wanted to do that.
So what would you say was the key mandate of this position and program that you were leading? Yeah,
so the key with PEPFAR, there was the truth is there was a lot of politics involved in the implementation of PEPFAR, and so we had to work across the aisle, across agencies to develop and clarify a role, because there was a lot of duplication occurring in countries. So CDC really, for me, we thought we would focus on our strength, which was surveillance and data collection. We were very good at counting cases. We were very good at measuring incidents, doing the things that we do well. Laboratory was another big part of what we were good at. So we wanted to focus on developing laboratory capacity in those countries so that you could diagnose people and so forth. The other area that we thought we were very strong at was doing what we call the implementation research, to really identify which programs work best and then expand those programs to reach capacity. And then we shared the treatment work with USAID and others. We collaborated very closely with the HRSA, with the Health Resource Services Administration, because they have the treatment arm in the U.S. And so we worked very closely with them to help with the treatment component. But that was equally shared across agencies. And then there were some other smaller areas that there was still some duplication. And like the work with orphans, that was pretty much all of the USAID. That was not our area of expertise. The area where looking at systems and putting systems in place, like drug distribution systems, because you had to make sure drugs got to where they needed to be. All of that, all of the logistics and things like that was being done mostly by USAID and the Department of Defense and so forth. So CDC tried to focus on the areas that we were good at, and that is surveillance epidemiologic studies, implementation studies, and then data collection, and then data dissemination, and engaging communities in that process.
And then PEPFAR comes on board, and you don't only have to work with those agencies, but there's PEPFAR, and it has to be all encompassing. I mean, how did that work?
Well, I think the one good thing I think that they did was at the time is basically saying in each country the embassy is going to be the lead for PEPFAR, and the embassies were the ambassadors and the DCMs, the deputy chief of missions, were the folks who really made sure we work together, and we had a process in place, and they had and I said, CDC had his areas of expertise, and that's what we tried to focus on. But that varied a little bit by country, and depending on what the country how the country developed their operational plan and how they divided up the work. But sometimes in some countries the work was divided by region. CDC took a region, USAID took a region. I mean, so it varied a lot from country to country. So it was challenging and of course exhausting. But it was challenging, but I think the work, even though it was challenging, there were a lot of very committed people in all of the different agencies, and despite the challenges of working together, I think they were very effective in getting things done on the ground.
Mm-hmm. So how did you? What do I want to ask? Like for instance. So you have CDC operating in cooperation with PEPFAR. I mean, how did the initial programming for that work to get that started? So
one of the let me just clarify. One of the mandates of PEPFAR was there was no separate agencies in country. We were all U.S. government, and CDC, USAID, Peace Corps, Department of Defense, if they were in country, all of the U.S. government agency worked under one umbrella, and that was the Department of State, i.e. the embassy in country. So when we talked about the work that was being done, CDC was doing X, Y, or Z, but it was all PEPFAR. So there was no individual agencies. When I was doing the Global AIDS program, it was the CDC Global AIDS program. When PEPFAR came along, it was PEPFAR, and there was PEPFAR CDC, PEPFAR USAID, et cetera, et cetera. So we were all under the PEPFAR umbrella. And the way it operationalizes that there was each country had to develop what they call a country operational plan that really spelled out the role of each of the agencies in that country. And that operational plan had to be completed and then shared with headquarters, and headquarters would review. And I was in headquarters. I was one of the principals representing CDC, and we would review these operational plans with with technical folks, and then we would make recommendations to the countries on how to adjust those. But yeah, it was one U.S. government.
Mm-hmm. So other folks we've spoken to that were involved in the program have mentioned like there were some tiffs and competition right at the beginning. It was not always very smooth. I mean, what would be your experience as far as that's concerned, if you experienced it, and how was it resolved?
Yes, as I say, it was not easy. That's true. There was a lot of competition, and both at the national level in Washington as well as in the countries. And a lot of it was resolved by having third parties involved. So, for example, in the country, which is where the most of the, challenges occurred, the embassy had to play a role. And oftentimes it was each country had in the embassy a PEPFAR coordinator. And that PEPFAR coordinator reported to the ambassador in that country. And that PEPFAR coordinator sometimes would have to, when CDC and USAID or whomever was involved couldn't agree on something, that PEPFAR coordinator with support from the ambassador would make the decision as to which agency would be the lead. It doesn't mean that CDC couldn't work on something that USAID was leading, but USAID was the lead. And so, but those kinds of issues, and I would say that happened most of the time. The two agencies would get together and they would try and figure it out. Because then I say that I mentioned those two agencies because they were the big players. USAID and CDC were the big players in the country, and so that's usually where the conflicts existed. Because and you can understand it. The agencies were very different in the way they work. CDC was much more on hands. They were always involved directly in implementing and supporting the projects, on the ground, et cetera. USAID worked a lot through contracts, and they used a lot of community organizations to do the work, and they were not so hands-on. So there was a different culture and a different way of doing things, and we had to learn how to work together. And it was more difficult in some countries than the other. And we did other things, innovative things, like periodically we would assign sometimes people to USAID to work with them on specific projects. I mean, in countries where there was that interest. And so so that we would work together. And I think oftentimes when we had people embedded in the different agencies, it worked much better.
So, I mean, much of your work, as you're saying, you're more hands-on as an agency. PEPFAR comes and you have to now be interagency. So, like, can you just explain to me, how does CDC or all of you work together in host countries? Like, where do you start from and where do you end? Like, we have this project and you want to do this A, B, and C. How do you get buy-in from the host country?
Mm-hmm.
Later on, I read that, one of the things you said were important in your tenure in your global work, global health work, was community involvement, as you said earlier, working with academic institutions and the host government is also important. So can you just explain to me, like, that whole continuum to be able to get the kind of results that you
Yeah, it's let me just first say that when PEPFAR came in, I was only around for a year afterwards, because then I resigned from my post and took on another position within CDC, a high position within CDC. So I wasn't as involved for about 7 years after, 3 years after PEPFAR came on board. But in general, the process, there's no way. The country operation plan was actually developed in close collaboration with the government and organizations in country, community-based organization and others in country. And usually there was a PEPFAR planning committee, a country PEPFAR planning committee. And that planning committee consisted of all of the interested parties, including CDC, USAID, all of the US government partners, all of the local government, national government, important national organizations and local organizations, and of course, multilateral partners. So sometimes at the table was WHO and others, where UNAs and others were relevant. So that country operational plan was informed by their engagement. And the country operational plan, as time evolved, had to be signed off on by government. As time evolved, that wasn't the case initially, but the country operational plans are basically not just what U.S. government wants to do. Now, the USG country operational plan then has to fit into a bigger plan, which is every country develops a plan for their country that looks at resources that are coming from U.S. government, from Global Fund, from other bilateral donors, and they have to put together an overall plan how they're going to do things in country. And so the country operational plan is only one leg of that overall plan. So it's a little complicated. And as you might imagine, some of the countries have challenges getting this done. So they would have to call on consultants. Sometimes CDC would help them, or USAID would help them with that process. But there was a plan, and it took a lot of work. That process sometimes would take almost 6 months to a year to get done, or even longer.
So you are talking about that you were working with partners at some point, or direct with the government and all of that. I'm a bit interested about the nonprofit organizations that you're working with. Like, how does one nonprofit get to be chosen to work with you guys and over another? What kind of criteria was that used, and what kind of things were you working with the government direct and others being,
Sure. So, of course, things changed over time. Early on, especially early on with PEPFAR, there weren't as many nonprofits, well, local organizations in country. So oftentimes there was only one or two, so you just funded those organizations to do the work. As time evolved, more and more organizations occurred in country, and the process had to be more competitive. And so there's an application process where let's back up. You have to put together what's called an opportunity announcement, a grant opportunity announcement. And so these organizations would have to then apply, and then there was a objective process to review these applications, and then decisions would be made on who got funded, and how much money they would get, depending on how strong the application was and and the outcome of the objective review. So there had to be more of an objective review process, and that process, and also at the country level. But again, there were instances where you knew, based on what you were asking, what needed to get done, there might have been only one organization in country that could do that work. Sometimes there might have been no organization in country that could do that work, and you'd have to look outside. And sometimes we could do what's called a sole source contract to get the work done. But that over time, as more organizations develop capacity to do work, it had to be competitive, and there had to be an objective process to make those decisions. And that's the way it tends to work. It worked most of the time, at least for CDC. I can't speak to how USAID did most of their work, but for CDC, over time, everything had to be competitive. The same was true for, we also had national partners here in the U.S. that we worked with universities. We worked with other organizations that provided technical, like the Family Health International, FHI, number of different organizations. And for them to get funded, it was a competitive process. And so, but when we might fund, sometimes it was a competitive process, and we would fund people to work in different regions depending on where they have capacity, because all of these organizations didn't have capacity in some countries. And what we didn't want to do is spend money helping them develop the capacity in that country before they could get any work done. But we did have a number of national organizations, what we call Beltway bandits, that were funded to do work in country. And because they already had a presence there, or they had partnerships that had presence there. And universities did a lot of our work as well, especially the operational and implementation research. A lot of that was done by, and some of the treatment programs were managed by universities.
Mm-hmm. So would you say that's the reason primarily why you had external partners coming to implement in those host countries, because there was lack of capacity?
Early on, there was lack of capacity, but part of the goal always was to make sure those organizations develop capacity in country. So they had to hire local staff, et cetera, and develop capacity in country. It became much more, early on, we were not as good at this as we should have been, and we didn't spell out as much in the grants and contracts. But over time, we got better at it, and the grants and contract really spelled out exactly what we wanted them to do in terms of developing local capacity. But the goal was to eventually get to the point where the research, the universities and others were not needed except in an advisory role. And the local capacity would be there in country. Some countries were able to get to that. Like, for example, South Africa, has more resources, already had a fair number of universities and others in countries that could do the work. And so South Africa was able to, a lot of that capacity, a lot of that work was then transferred to local organizations and local universities and the government, et cetera. In other countries, like Botswana is a perfect example, where the U.S. government spent years trying to investing in a medical school and different things to try to develop capacity there. And over time, because of changes in government, it just didn't work out. It's a little bit better now, but it just didn't work out. So some countries were much better at in terms of I should say some countries, we were much better in some countries than others in helping to develop that local capacity.
So PEPFAR, for instance, was meant to be an emergency response. We are 20-something years, and it makes sense that, we have to hit the ground running, and whoever has capacity is what we're going to use, because, we can't wait, and hence we have a lot of these external resources coming in. But again, you're saying that at some point you realize that there has to be some kind of transitioning and building of capacity. Can you explain what those kind of efforts have been, especially for buy-in of the host countries, for leadership and capacity to make sure that it's there? Right now we're at a point where resources are not as much as they would be, so we really would want those host countries to be able to move on. So just explain the sustainability effort that has been there or is underway, or whatever you think should be done to make sure that there is that kind of.
Yeah, I can't speak to what PEPFAR has done in the last 8 years or so, because I've been away from the global work. But
during the time that you were there,
I think I think they've gone a lot further with the sustainability effort than it was when I was there. Again, developing capacity in country takes time, especially when you're talking about surveillance capacity and some laboratory capacity, et cetera. So let me use laboratory capacity building as an example. So there were a number of things that we were doing during my tenure and immediately afterwards to help develop laboratory capacity, because diagnosis was really important, and having accurate and reliable diagnostics was important. So one of the things we did is, in every country that we were involved in, we worked with the national laboratory to develop in-country capacity to do all of their own diagnostics, especially rapid tests and then confirmatory tests, et cetera. And that involved not only working with them to train and, but both to hire additional staff using U.S. government funds. So these are local staff, local people that were hired and trained to become trained as laboratory technician and become more proficient in doing their work. And then we would send them away for training, et cetera. So we developed laboratory capacity in country. And I think that's the one area where I think there's been the most success, is developing laboratory capacity within country. Because, and part of that was not just training and getting and hiring people, but a lot of it was also making sure, having physical space and equipment and having maintenance agreements in place that were reliable, et cetera, et cetera. So a lot of work went into developing laboratory capacity, because the lab was, in my opinion, was the foundation of having an effective national program. And so laboratory was what we focused on, and that was a CDC strength. And that I think we've done very well, to the point where now why am I blanking? It's in Ethiopia. The African Union has the African Union is leading that work, and CDC and others are we're really just consulting and buying and just supporting them in any way we can. But there's laboratory capacity in Africa in many of the countries is really pretty good, and that's an example of, I think, where the U.S. government has done a great job in helping to develop capacity. I think the other areas where it's been more challenging is developing sort of the epi capacity. People who are able to do surveillance, people who are able to do sophisticated analyses and look at their data and then use that data to use that data to inform decision making. And part of the reason that has been such a challenge is that, one of the challenges we had when I was there, we would work with the national government and with the universities to develop, strong folks in epi and so forth. And then they get hired away by the World Health Organization or UNAIDS and because there were better opportunities outside their country. Or even if they stayed in country, they were no longer working for the government. They were working for one of our implementers. They would hire people away. And so there was always this, what I call a brain drain. You train people, you get them to the point that they're able to do the work really well, and then somebody hires them away. Yeah. So I think that was more challenging. Laboratory was not as, we didn't have that problem as much on the laboratory side. And that's why I think laboratory was much more successful. So that's just one example.
Gotcha. So what would you say was your highlight when you were working in this position? And of course, like your challenges in that position.
Yeah. I would say my highlights were, since I was the director of the program, I did get the opportunity to visit all of these countries, most time once a year, sometimes twice a year, depending on what was going on. But for me, the highlights were actually going out to the field and visiting the communities and seeing the difference that was being made. For example, one time I went to Uganda. And Uganda, as you know, is pretty rural, and so they took me to an area where it's an area that borders Kenya. I wonder what's Kiboga is what it was called. No, it's not Kiboga. I'm sorry, I can't remember. Forget the name. But anyway, it was a rural area. There was really no infrastructure. But what CDC and what the U.S. government had done there, or what our office had done there, is we had, in partnership with the government, developed a community program that basically provided comprehensive care to people being diagnosed and needing care for HIV. And there were people with motorcycles that would go out every day to the villages and to the communities to make sure people if they were taking antiretrovirals, they were able to get the antiretroviral. They would get the antiretrovirals and they would monitor them and just going out to the actual some of the villages. I went out on not on the motorcycle. I went in a Jeep, but I went to some of the villages and met with the village leaders and heard them talk about the difference it had made in their community. Those were the kinds of things that were the highlights of my visit when I went to countries. I think the biggest challenges were the politics and people. For me, all I cared about was making a difference, and I didn't care who took credit for the work as long as the work was getting done, and trying to get even my own staff to understand that you shouldn't be fighting about who's getting credit for this. What you should be fighting about is whether we're doing the right thing for and patients and people, the people that we're serving are getting what they need. So getting people to sort of stop being selfish and think about what they're really there for was somewhat of a challenge at times. And that was, to me, the most frustrating thing. And it happened, and not just with partners, but also with my own staff. And I would always remind people, why are you here? You've come out, you've made a commitment to work in the country and work on the ground, and yet you're fighting about who's going to be first author on some paper. That's not important.
Groundbreaking papers.
Yeah. Yes.
But it is important.
So, but those, and then, the other thing that was somewhat disappointing is in some of the countries, you do all this work and you do a lot of work, helping to strengthen the Ministry of Health, and you get somebody who comes in and just, how should I say, dismantle it all. Some, new leadership that comes into the Ministry of Health who is not committed and not on board, and they just sort of dismantle it all, and you're sort of starting over again. So every time there was a new election, you always had to make sure you did your due diligence to meet with the Minister of Health and meet with the head of the HIV program and different programs to make sure they were on board and aware of what was happening and make sure they understood the kind of support that we could provide them.
So it was when you were director for the Global AIDS program that you made that memorable trip with Secretary Thompson, Julie Gerberding, yes, and other government officials. Will you tell us more about this trip? Was that your first time in Africa?
Oh.
What were you expecting?
No.
What was like the vibe around the other officials that were there? Just share what you can remember about that trip.
So I had been to Africa many times before then. So what this trip was strategic. One of the things that this is before PEPFAR was authorized. we needed to convince folks that PEPFAR was the right thing to do. And and then Secretary Thompson decided that he wanted to take 99, 100 of his best friends. No, just kidding. That's not correct. He wanted to take some important leaders, both, everybody. And there were congressional staff, there were religious leaders, there were pharmaceutical folks. Wanted to take these people out so they could see what was happening firsthand on the ground. And so that's what we did. There were about 100 plus folks, just over 100 folks. And then there was several pharmaceutical companies that were doing work in Africa, and we were partnering with them. And we went to, I want to say it was 5 countries in 7 days. And then there were site visits. I mean, it was a huge effort by our folks on the ground to arrange these visits. But we had an opportunity when we took them to the countries, we made sure they saw a prevention program. We made sure they saw treatment programs. We made sure they had opportunity to interact with local folks who were benefiting from the U.S. government work. And so that trip, even though it was a painful trip for me because it was exhausting and, having to, I was one of the folks who were providing information and education to many of the delegation. And so it was a little challenging, but it was a very effective trip because they were so impressed at the work that was being done in what they considered to be rather difficult conditions.
Against those prevailing notions that it would be difficult.
Exactly.
So they had to see firsthand.
They had to see firsthand. And of course there were testimonies given by patients and by organizations that were involved, et cetera, et cetera. So it was a very, very effective trip. And even though, as I said, it was exhausting for me, and I was not exactly on board initially, I think it was the right thing. I know it was the right thing to do, and it made a difference in getting authorization for PEPFAR.
I mean, it was important, and you're like one of the leading people. Can you recount like what kind of feedback did some of the delegates say about, this trip?
Well, I can tell you specifically, there were, one of the things, I spent a lot of time with some of the religious leaders. And even though, and then many of them, the few that I had an opportunity to talk to, they really were impressed by the trip because many of them had never been to Africa before. They had and they had these notions of what Africa was that were totally off base. And when they got there and was able to see that, they were not savages running around. They were intelligent people who understood, who even without education were really very, very smart and intelligent folks. And also the fact that people were excited about being able to take medicines and was taking them every day. They just couldn't believe that folks would do that in Africa. I mean, these were, it sounds pretty awful, but that was definitely the case. And then you had to also sort of address some of the stereotypes they had about the sexual habits of folks in Africa. There were all these rumors, and some of it was true, but the whole idea of the ABCs, some of them thought was not appropriate. They thought it should be abstain only and nothing else. You shouldn't talk about condoms. It should be A and B, but not C. And I said, we had to convince them, and we had data to show that, sure, there are people who can do A and can do B, but that's not the culture in many of the countries. And condom has to be an option for people who want to prevent infection. Because at that time we had nothing else. We didn't have we didn't have PrEP or PEP and stuff like that. So condoms was really an option for folks who could not abstain and could not be faithful. And having them to understand the role of women in many of these societies and the fact that they had no power and really could not protect themselves was something that we had to get them to understand.
So 2020, 2014,
Mm-hmm.
you transitioned into a new role in
Yes.
CDC again.
Yes.
Keep going higher, different responsibilities. Can you tell us about that role and what was the mandate?
Sure. So yeah, in 2014, I was selected through a fairly rigorous process to become the director of the domestic HIV program. It was called the HIV. It's called Division of HIV at that time. DHAP, Division of HIV/AIDS Prevention. We've since changed the name, but yeah. But so, and the mandate there was to really. I was responsible for all of our national HIV prevention, surveillance prevention, and treatment related activities. And part of the mandate was to work collaboratively with our domestic partners like HRSA and others to really get the work done. And so for me, when I got the job, I took the job. One of the, I was very familiar with the data and what was happening with HIV in the U.S. and it was certainly becoming a black and brown disease. So one of the things I wanted to do was to hear from the community. So I spent my first year really doing a lot of work out, going and visiting, going to and meeting with organizations to hear what they thought the problem was, what they thought some of the solutions were, and then we put together, after that first year, sort of our approach to how we were going to do things. But one of the big emphasis during my tenure there was to really have the evidence basically direct us to what we need to do. And so one of the things that was clear is that we were having a major problem with HIV in Black and brown young people, and the numbers are going up. So we, based on the data, started a number of programs that were targeted towards young people, especially young Black and Latino men, gay men, and women, because women was also another big group. But that job was a big job, and it was very different than the global job, because in the U.S., HIV is very politicized, much more than it is in the global community. It's gotten worse in the global community over the years, but it was and I did not fully understand what I was getting into initially. But my travel that first year to the community and hearing the different perspectives really helped me to get an understanding of what was needed and how important it was going to be for me to engage the community as much as possible. Even, I say as much as possible, we need to engage them in helping us to think about what the programs are that we should be doing. And then once we implement these programs and evaluate them, engage them in the outcomes of those evaluations, and then helping us think about how to improve them or get rid of things that weren't working, et cetera, et cetera. And then, of course, we did a lot of surveillance, and one of the things that for me that also became important was that making sure when we did surveillance reports, we talked with the community beforehand so that they knew what was coming, so that they can prepare. And they were actually, the goal was to make the community an ally rather than an adversary. Keeping the community informed to me was really important, and having them help us think about how we frame certain things so that we don't further stigmatize people in the community was really important. That was a big part of what I tried to do. Of course, there were folks who didn't necessarily agree with my approach because I was seen as being too close to the community at times. But that to me, I think was very important, and I think it was effective because I think during my tenure, we had very few complaints coming from the community as compared to the years before I was there. But it was a lot of work, and I think that I think as you may know, I was the first African American director for the program, and the timing was right because the epidemic in the U.S. was becoming, as I say, a Black and brown epidemic, and having a person of color leading the national program, I think, was important, and that's part of the reason I took the job, because I didn't go out I didn't actually seek this job. I was approached by leadership and asked if I would consider it. And after thinking about it and talking to a lot of people, I did decide to apply. But it wasn't a job that I sought initially.
Is that the DHAP or the GAP job?
The DHAP job. The GAP job, I was happy.
You passed that one. Yeah, it does seem like it's quite different. So for me, I was just like, why was that important for you to move from the global to the national? But I think you've touched on that.
Yeah.
So I won't ask that again. You did mention that engagement with the community was a very important strategy that you sort of embraced with this particular role, and there were issues like, I mean, can you just highlight, not in too much detail, like what issues really came up when you're engaging with the people, the programs that you tried to implement?
So for example, I mean, that was before I took the job, I talked to a number of folks that I knew, because even though I hadn't been doing domestic, I had friends who were actively involved in investing. They said, and one of the things that all of them said is that the community you need to make sure if you take this job, the community is engaged and involved, and you need to hear from them. And so one of the things when I went to the community, there were several things that I was hearing. One was that in my community, it's the Black and Latinos and the Black women that are mostly affected, but the resources are not going to them. The money that you're giving to the states, it's not going to the community organization. So you need to have initiatives that are directly funding community-based organization, rather than, because we were relying on the states looking at the epidemiology to fund the community-based organizations. Trickle down to the grassroots, and it wasn't happening. And unfortunately, the relationship between the federal and the state is sometimes very tenuous, and even though we give them the money, we can't necessarily force them to do what we need to do. So we decided that we heard them, and what we did is we developed some specific initiative to fund local organizations. So there was an initiative that were developed that were targeting young Black and Latino men, and it was called the Young Black Young MSM Initiative, and it was really targeting community organizations that serve those communities. We also had initiatives that targeted Black women, and again, wanted to fund organizations that serve those communities, and that funding went directly to those organizations and not through the state and local health department. And we also during those first, when I got there, all of the grants that we give to the states are 5-year grants. And so we were in the middle of those grants, but and so we started a process of planning for the next 5 years. And one of the things we did is we wrote the grants differently, and we basically spelled out that a certain percentage of the funding that you got must go to community-based organizations, and they need to be going to the organizations that are actually doing the work. Because what was happening in a lot of these places, the money was going to some going to community-based organizations, but they were these big organizations that were mostly white-led, and they would have a token Black or Latino person in a position with no authority, and the resources even from those community-based organizations weren't getting to the people who needed so it was trying to be more targeted. And of course, as you know, that was somewhat challenging because there were some folks in politicians who didn't think that we could target, that it was illegal for us to target money that way, but we were doing what was based on epidemiology, and we had a very objective process of trying to get that done. I don't know how much of that is going to change now, but we were able to do a number of things that really targeted communities. Similarly, right before I left, we actually started an initiative that an initiative that targeted transgender population, because HIV is becoming such a problem among transgender, and I'm pretty sure that's going to be gone or going to be stopped. But the idea was to use the data. We have very good surveillance data, very good incidence data, and using the evidence, we would target our programs to where they needed to be. And we felt that we had to have a combination of national programs that targeted CBOs, community-based organizations, as well as be more directive to the states in terms of how they were getting their money down to the community.
So you have this long history of working in Africa and how well it worked out working with communities and all of that. So what are some of the lessons that you've learned from that kind of work that you think are important or should be considered for the U.S. response? Because I mean, clearly HIV is still an issue in the U.S.
Sure. I think there's probably three or four that I think are really important. And let me say, I think at the top of the list has to be the critical need to engage community in everything that you do. Because, it's amazing, the communities know what works best for them. And your approaches have to consider what the community is telling you they need. And part of that is also being willing to meet the community, meet people where they are, so that people shouldn't have. If you've got a rural area where there's lots of disease, people shouldn't have to travel 20, 30 miles to get to a clinic. We should be taking services to them and using technology to help us do that. So community engagement and hearing what the community has to say. I think the second one is to me, data. Evidence is really what should be informing what you do. And if the evidence says that 90% of 40% of your new infections are occurring in young Black and Latino men, then that's where you should be directing a significant amount of your services. And so using a data-driven approach, I think, is critical if we're going to really do this. And we need to somehow, data is somehow not allow the politics to drive 100% of it. You can't do. Let me just clarify. You cannot. Data are critical, but policy is a combination of data and politics that lead to policy. But politics should not be 90% of decision making. Data should be at 90% and politics 10%, if any. But data should be the driver in terms of deciding how we move forward. The other thing I think is critical is partnerships. And one of the things that we've not talked about, which I thought was important in the global arena, is the private sector and the role they need to be playing. And I think even now, even before this administration, I thought private sector needed to be playing a bigger role, and I think it needs to be even a bigger role now, given what the future may bring. Private sector can make a huge difference, both domestically and globally, and we've seen it in places like Botswana, where the private sector played a major role in helping them really get to their very low rate of prevention of mother-to-child transmission. They basically eliminated mother-to-child transmission in Botswana, and that was a public-private partnership. So private sector is important. And just to give you an example, businesses, if they're going to get, I think it's important to get businesses involved, both at the national level and at the community level. But the businesses have to have their house in order, meaning that if you're going to work with the community, you got to make sure you're taking care of the people that are in your employment, making sure they have access to good health coverage, and if they're HIV positive, have access to HIV coverage and things that they need. If they're at risk, have access to prevention, et cetera, et cetera. So partnerships has to be with government, private sector, community, and academia. And then in some cases, I think getting the religious community involved is critical. Another area that we so partnerships for the three I've mentioned. And then the fourth one I would say is how do I say this politically? Our health systems is a major issue. In developing countries, the health infrastructure is not there, but the health systems with the focus on primary health care is I think is right, because people, in many countries, where the infrastructure exists, they have primary health care facilities that takes care of the whole patient. this, having fragmented healthcare where you have to go to this place to get that, it doesn't work. And that's what we have in the U.S. And unless we can really do something to improve our healthcare system and become more primary care focused, where you've got a primary care doctor who can basically take care of all the basics, and you only see a specialist when something is really complicated. Our system has to change, and that means changing a lot. So to me, the places where I've seen things work the best is where they've got really an integrated healthcare system that takes care of the whole patient, and you're not just going someplace for your HIV disease or someplace for your hypertension or someplace for your diabetes, et cetera, et cetera.
And which is the case in Africa, because when somebody goes in, then they're taken care of comprehensively, and they only refer special cases.
That's right. Mm-hmm.
So you're talking about, just wanting to dive in a bit, you're talking about the special role you saw being played by the private sector in Botswana. Can you clarify what happened?
So Merck made a huge investment in Botswana and provided funding to support their prevention of mother-to-child transmission program. But it wasn't just the money. They also provided human resources, et cetera, and worked with the government to develop a strong national program. They made sure there were drugs available, et cetera, et cetera. And the Gates Foundation was also involved. I think it was Merck's, Gates, and it's a private sector foundation. I hope I get it right. I'm pretty sure it was Merck. But the Gates Foundation was involved, and it was a huge initiative. And then, of course, later on, the Global AIDS Program, the Global Fund to step in. But Botswana, but it was the groundwork that was done by this public-private partnership that really got them on the right road, on the right path to eliminating mother-to-child transmission in Botswana. So that's what I'm talking about. But the private sector, really contributed the resources that were needed early on, and then to help develop capacity within the national program to get the work done. And the government, CDC and others were involved, but it was really the private sector funds that did it. And then the government was able to, with Global Fund money and other, take it over.
So you spoke about a scenario whereby you have data that really tells us what to do as health professionals or people that are working within the national HIV response field. But you also have, politics that also takes precedence. I mean, what would you say would be the way, like in an ideal circumstance, what would be the advice that you tell so that, as we have seen that using data informs better decisions, as was displayed by the work in PEPFAR and in Africa and your CDC work. So how would you convince, or what should be done to actually make sure that happens for the benefit of the US domestically? Because this works well elsewhere, but it's not benefiting the US, although it proves to be a best experience,
Sure.
Best lesson. What could be done?
Well, I think one thing is that one of the things that I think is when you're doing advocacy work, and advocacy to me is advocacy and education is what I think is going to be key. A lot of time we tend to go to the places where we feel comfortable, where we know we've got support. There's got to be a stronger emphasis on working the other side of the aisle, dealing with the folks who are the skeptics, doing what you getting in front of them and making sure they have access to the data and making sure they understand the data. But more importantly, personalizing it. I think that when doing your homework, you can sometimes, for almost everybody, even the politicians who are the most egregious, they know somebody that have HIV. They know somebody who's gay. They know somebody who's probably, they may not know a transgender person, but making sure you personalize the story when you're meeting with them is important. And because when we were doing work early on with PEPFAR, and when we were doing work or my early years, in my first few months in the domestic program, when I became the director, when we went and met with congressional staff or congresspersons and senators, we made sure we had a personal story to tell that was relevant to them. But it meant doing homework. So I think that's important, and I think that's going to be even really important as we move forward. And so one of the things that I am doing is I'm working with an organization that is an advocacy organization that does what we call AIDS Watch, and they go on the Hill and they do a lot of advocacy related work. Well, we're going to be targeting all of these folks on the other side of the in the House who are, who are anti-LGBTQ, anti various things. But the approach is going to be to personalize it and talk about data, and then talk about data from their community, data from their jurisdictions. So it's a lot of work, but it does work. And I can tell you that last year when we did this work, there was, before we went on the Hill, there was the domestic HIV budget was going to be cut dramatically, but we spent 2 days on the Hill and we saw hundreds of House and Senate folks, and a week later the bill was passed and there weren't any cut. It was level funding. So I think it was effective. I know it was effective, but it's a lot of work, but that's what people have to do. But that's national advocacy. But I think also you've got to deal with this on the local level. I think it's got to start at home. So doing work at home is critically important. Like in the state of Georgia, we need to be doing stuff here with the leadership and with the communities. And then the other thing, I'm talking about the U.S. now, is this is broader than HIV, but sometimes no matter what you do, you're not going to convince people otherwise, right? And so that's why I think some of the community work that you do in community is going to be important, because you got to get people mobilized so that they get rid of these people who are not, they're just bad people, mean people. And there are some people who are just mean and they don't really care about anybody. And that's where people voting makes a difference.
Oh, yeah. Okay, so PEPFAR has undergone some congressional disputes across, its tenure and of authorization and reauthorization processes. And again, the future is at risk, as we might anticipate. So do you have any thoughts on this, that you're willing to share with us?
Thoughts on the future of PEPFAR? Thoughts on...
all these people that are benefiting from this kind of work, great work that has been done. CDC as well, because at this point, we have the pause and all of that. So, what are your thoughts? What would you share about that?
Well, just maybe,
Takeaway message, for consideration. Like you said, you did direct lobby in the Hill, for certain things to change. What would you say?
Yeah. God, there's so much going on that it's hard to sort of just encapsulate it in a couple of things. I think that the people that are being impacted by those the most are the folks in the countries in these countries that we have been working for the last 15 years. 2004, so 20 years, and all of a sudden within days, there are people who are not getting services, they're not getting their medications, they're not doing. There's a lot of things. And people are dying as a result of it. So I think that one of the things, as I mentioned, I said one of the things that we've got to do is, and I'm harping back on data again. I think the private sector has got to step up. And one of the things the private sector can help us with is document the impact that these irrational decisions have had on communities, especially the communities where we have had invested so much. Look at people dying, unintended infection. Get the data. Help us get the data to show the politicians the impact, the adverse impact that their decision has made. And we know that when you have an unhealthy country, it leads to an unhealthy political environment, and that is not good for the U.S. So there are things that one can do. So that's one thing I think, is trying to see if is there a way. But the other lesson I think is that, maybe I shouldn't say this, but one of the things that I think we failed at is the whole, you talked about the sustainability issue. You know, we've been doing this for 20 years, and many of the countries, some of them have, but many of the countries weren't able to, and did not have even though they had a sustainability program or a plan, they weren't implementing it, and we weren't pushing them enough to implement the sustainability program. And so, you know, if we had something that, if we had really pushed what we were preaching, then it's possible that, you know, the impact would not be so dramatic. But unfortunately, I mean, that didn't happen. So, you know, I think as we move forward, we've got to think about sustainability, and there needs to be less reliance on government funding. And that's just not for the international program, but also here in the U.S. Many of our community-based organizations now are really going to be suffering, especially if some of the things happen that we think might happen. But we've got to think about other ways to generate revenue so that we can continue to do the things that we need to do and not be so reliant on government. And I don't know what all those answers are, but I think private sector is part of it, part of the answer. But also getting you know, other sectors involved, like the religious sector and all that, and getting them to do more. So.
Very last question, and we conclude. All of this great work that you've been involved in, how has it impacted you personally? The person you've become to be, what you believe, what you support. That's my last question. I promise.
Yeah. Well, I mean, it certainly has made me more empathetic about a lot of things. And but you know, let me just back up and say, you know, being raised by a single mother, and who always talked about the importance of education, the importance of community service, all those things we did growing up. So my career is an extension of that. And you know, one of the things that I think that's true for me and many members of my family is that we tend to get involved in things. But you know, after being at CDC for 35 years, I learned a lot about the community and how important the community is to everything that we do, not just HIV, but all of the things all the prevention-related environmental stuff, chronic diseases, et cetera. And so, you know, since I've retired, I've really focused a lot of my efforts on working with community. So I'm serving on the boards of community organizations. I'm actually overextending myself a little bit, but to me it's so important that the community be recognized and engaged. And I think given my experience, given the access that I have, I think it's just so important for me to be involved. And that's even more true now, given the recent political environment.
Thank you so much, Dr. McCray, for your time
Yes.
and valuable insight. Hope we did not bog you down for too long and you enjoyed the interview.
Yes.